Test, test, test. Ray, can you hear me? Can you hear me, Ray? Hello, Ray?
I can hear you.
Cool. All right, Bree, why don't you tell me if the slides move? They moving? They moving, yes or no? Very good. It is time to begin. We are a little thin on the ground today. We have a lot of sick colleagues. So whatever's going around, try to stay clear of it as best you can. I know that's asking like you, that's like asking you to not breathe or something like that. It seems to be passing through the campus, and it doesn't really care who gets it, but a lot of people are getting it. So there seems to be an upper respiratory something, and then there seems to be a stomach something. So the stomach something seems to have kind of worked its way through the volleyball team. And hopefully they're all immune to it now. Then there's some sort of upper respiratory something that seems to be also taking its toll as well. Is that what you had, Karen?
Yeah, I was just like a lot of
Yeah. My oldest daughter just is on the downside of that too. It's pretty nasty. So the next two chapters are about blood-based conditions that are inherited. These are both conditions Well, one of them you're more likely to see than the other. Sickle cell disease, there's a pretty good chance you'll see that in your practice. Hemophilia, you might see. It depends where you practice. You're more likely to see it in a cosmopolitan area than you are in a more rural area. But it is an inherited condition, so it is really worth our consideration. The next chapter is sickle cell disease. That is medically quite interesting and keeps the nurse quite busy as well. So let's start with a word of prayer, then we'll get into hemophilia. Father, thank you for this cold day. Thank you for that very stiff northeasterly that kind of cuts us in half when we go outside. We thank you for the sun. We thank you for the crocuses and tulips and daffodils making their way up through the sod. Thank you for students here. For those who are ill, Lord, please heal them. Watch over us, please. In Jesus' name, amen. All right, so we're going to look at hemophilia, its genetics, and what to do essentially with people with a family history of hemophilia. So this is to remind you of that pathway that tortured you last year, both in A&P and also in pathophys. So the blood clotting pathway consists, first of all, of a primary pathway where the platelets are activated and they form a platelet plug. In organisms with blood systems under low pressure, this is all you need. So for example, if you look at sea cucumber, which lives under the sea, it has essentially this same sort of setup, except you don't have all this bishwhack. You just have hemocytes that swell up and plug any injuries. That's all they need. Their blood system, excuse me, is under low pressure. Our blood system's under high pressure. So that platelet plug needs to be reinforced, and it's reinforced with fibrin. So this is a very cable-like sort of macromolecular assemblage. These are proteins, they self-assemble into these large rod-like structures, and these large rod-like structures lay across the platelet plug and reinforce it. They act, if you will, like a net on a bunch of fish. The fish can't really stick together, but the net essentially holds them together. So think of this kind of as a net, if you will. And so the net will hold the fish in place and you'll have a proper plug. Both of these can go awry when it comes to genetic diseases of hemostasis. Also, as we will see in farm, both of these can be attacked if you want to prevent someone's blood from clotting. So there are antiplatelet drugs. They're used mainly in arteries. Then there are anticoagulants. Those are used mainly in veins. Returning now to the subject at hand, there are two ways essentially to activate the coagulation pathway. There's an extrinsic pathway that's really pretty easy, and an intrinsic pathway that's a right bit more complicated. The extrinsic pathway utilizes this blood-based protein called factor 7. Factor 7, when it encounters tissue factor, is activated and it becomes a protease. Tissue factor is liberated when tissues are damaged. So let's just take, for example, the example of a Hannah over here who plays softball. And let's say Hannah says, oh, I'm going to really take the inside plate away. I'm going to grab the plate on this pitcher. So the pitcher says, I'm going to make her back off. So she throws inside and she throws hard. But she didn't quite get as inside as she wanted to. She gets Hannah saved right in the end. and it's going to get a, what do we call it? Bruise. That's due to blood vessels getting broken in her hip after getting drilled, essentially, by the opposing pitcher. The muscle and the capillaries have tissue factor on their surfaces. When they are damaged because of shear forces or trauma or something like that, they release the tissue factor. Tissue factor binds to factor 7. Factor 7 is then going to activate the common pathway, which includes factor 10. So as you can see here, its ability to activate the common pathway that includes factor 10, it goes from 7 essentially straight to 10. The intrinsic pathway, so the intrinsic because it occurs within vessels. If you have a vessel that's compromised, now the blood is going to experience a very highly negatively charged surface in the form of collagen. Collagen is found outside blood vessels, not inside. You sever a blood vessel, now the blood experiences collagen, von Willebrand factor, which is soluble in the blood, will bind to the collagen and line up. That gives the surface where the prekallikrein protein will get activated. It essentially clumps together and it forms this high molecular weight kallikrein. Activating itself, then prekallikrein will clip factor 12 into an activated form of factor 12. So inactivated factor 12 is like this, activated factor 12 like this. Factor 12 will then work on factor 11. Factor 11 then will activate factor 9. And then factor 9, with a little help from its friends, namely factor 8 and factor 9. And then factor 5, they form the so-called 10-ACE complex, the 10-ACE complex. And the 10-ACE complex clips factor 10 into an active form of factor 10. And then the active form of factor 10 converts prothrombin, thrombin, and the thrombin is what clips fibrinogen into fibrin. Fibrin, if you stick activated fibrin in a test tube, it self-assembles. Self-assembles into these long fibers. And those long fibers will take the platelet plug and reinforce it. So the genes that encode factor 8 and factor 9 is found on the X chromosome. And loss of function mutations in the genes that encode claudin factor 8 and claudin factor 9 will prevent the intrinsic pathway from effectively working. As you can see, because the extrinsic pathway also will give some help to these, it can work on factor 10, but very poorly. It tends to work over here. The extrinsic pathway isn't going to work quite as well either. So this is going to really throw a monkey wrench into the clotting of blood if you have mutations in either of these two genes. Big part about these is that both of these genes are X-linked. Therefore, they will occur predominantly in males. Predominantly in males. Biggest thing you're going to see is a family history of hemophilia in males. So family history here is going to be crucial, absolutely crucial. Let me read you some clinical vignettes that will give you a clue of what hemophilia looks like. And hemophilia is first detected usually in babies. So we have this kid, his name is Braden. Braden is very young, he's 5 years old. He just had circumcision and he won't stop bleeding. His mother is worried because he has a recurrent history of blood accumulating in his joints after minor falls. This is called hemarthrosis. It occurs after minor falls. Now, those of you who've been around little kids who are trying to learn how to walk, how do they learn how to walk? Right, but usually they grab onto stuff and they then they crawl, then they stand, crawl, stand. Then once they learn to walk, then they start to run. And then you have to catch them. As was before, catching them was easy, you have to chase them. So falling is really a part of learning how to walk, isn't it? Now, this is where you become very thankful for heavily padded diapers, because very often they fall flat on their tush usually. But a fall like that can cause these enormous bruises in joints that actually cause a good deal of pain within the joint. And the child may have a lot of pain when they try to move their limb. So hemarthrosis after minor falls. Family reveals that a relative of his mother, that's significant because the gene is going to come through the mother if it's a boy, suffered from a bleeding disorder and died from bleeding out. Let's have a second one of these little clinical vignettes. There's a 3-day-old preterm baby. Let's call this baby Harry. Harry is bleeding severely from the umbilical cord. Mother states she didn't get the standard care after delivery, so you order a CBC, and then you order these 2 tests, prothrombin test and a prothrombin time test. Prothrombin test is going to test the extrinsic pathway. Prothrombin time test will test the intrinsic pathway typically. Both these kids, Braden and Harry, have normal platelet counts. Braden has a normal PT, but his PTT time is elevated. Harlow has an elevated PT and PTT. So both of them pretty clearly suffer from a bleeding disorder. Can we agree with that? And platelets have nothing to do with it. So the problem is not here, the problem seems to be here. All right, so let's look at hemophilia A. Hemophilia A, so-called classic hemophilia, is due to mutations in the gene that encodes clotting factor 8. This is a loss of function mutation typically. Hemophilia varies from person to person, and the clinical manifestations depend on how badly factor 8 is inhibited. Some mutations in the factor 8 gene reduce the activity of factor 8. Others completely abrogate the ability of factor 8 to work. So because of that, you'll see variability in the severity of the disease. And of course, you have X-linked recessive inheritance. Now, since you have X-linked inheritance, can a child, a male child, inherit this from their father? No, impossible. It's absolutely impossible. Had to be inherited from the mother. So your medical history is going to lean very heavily on the mother's medical history. I always get this question, what if the child's adopted? You do the best you can with what you have. So that's hemophilia A. Hemophilia A, factor 8 is the one that's deficient. Hemophilia B. Here, the loss of function mutation is in the gene that encodes factor 9. Factor 9. Once again, you have variability in clinical manifestations. The variability depends on how badly the mutation inactivates factor 9. Clinically, it's very similar to hemophilia A. In fact, I think it's fair to say that in terms of their clinical manifestations, the two are indistinguishable, frankly. There is a hemophilia C. Hemophilia C is an autosomal recessive disorder that affects both males and females. This causes deficiency in factor 11. So if someone has hemophilia C, that means both mom and dad are carriers. Consequently, hemophilia C is not nearly as common as hemophilia A or hemophilia B. So you have variable expressivity of both hemophilia A and B. The way it affects the individual with it is quite variable. Some people show very severe manifestations, others not so severe. So typically what you'll see are very large bruises after very minor trauma. This is simply called easy bruising. They also suffer from something called ecchymosis. Ecchymosis. Anybody remember what that word means? You probably heard that last year. Does anyone have a distant recollection of what it means? The rest just won't leave. Ecchymosis is bleeding under the skin. Bleeding under the skin. So trauma will tend to induce bruising and then bleeding under the skin as well. You'll also see deep tissue hematomas. And then you also see the hemarthrosis as well. Blood in the joints. And you see that here, hemarthrosis. The other thing you commonly see in patients with hemophilia is posterior epistaxis. Epistaxis very simply means nosebleeds. Well, why don't they say nosebleeds? I don't know why they could call it epistaxis. And then, of course, GI bleeding, which you see here with hematochezia or melena. You also see urinary bleeding. Urinary bleeding as well. You also see persistent bleeding after surgery. So all features of hemophilia. The most dangerous complication of hemophilia is intracranial bleeding. Intracerebral bleeding, bleeding into the brain. That can cause a stroke. It can cause increased cranial pressure, which can lead to herniation of the brain. So with respect to this variability, if their gene product or protein, if it has anywhere from 5 to 40% of normal activity, their manifestation will be mild. If their gene product is 1 to 5% normal activity, then their manifestations usually will be moderate. If their gene product is less than 1%, then their disease will be severe. So 5 to 40%, mild, 1 to 5%, moderate, less than 1%, severe. Severe. Unfortunately, most hemophiliacs have severe disease. Repeated hemarthrosis can cause the joint to deform. That can restrict the range of motion. It can cause chronic pain as well. If we look at diagnostic tests, people with hemophilia will have prolonged partial thromboplastin time, PTT tests. So this will be elevated in people with hemophilia. But the PT count is going to be normal. Also, the platelet numbers will be normal. And that should be one of your tip-offs. PT will be normal, PTT will be elevated, platelets will be normal. The lab can very effectively tell you if it's hemophilia A or B, because labs will usually have isolated protein they can throw into the blood. If it doesn't clot and they put in factor VIII and it clots, that tells them that factor VIII is the one that's missing. If they have hemophilia B and they throw in purified factor VIII and the blood doesn't clot, then it can't be hemophilia A. If they put in purified factor IX and the blood clots, that tells them factor IX is the one that's missing. It's hemophilia B. So by doing these so-called mixing tests, that in fact is a way to determine, if it's hemophilia A or B. Now, if you have mild disease and you need to increase the expression of these genes, there are some ways to do that. So estrogens can be used in females, oral contraceptives, epinephrine. Vigorous exercise, except vigorous exercise will tend to increase the risk of bleeding. Desmopressin, all of these will increase the levels of those particular clotting factors. The most common way to deal with people with hemophilia is to use purified proteins, because these proteins have been cloned. They've been overexpressed in microbes that have been genetically engineered. So these proteins are widely available and they're not nearly as expensive as they used to be. So by getting infusions of these proteins, purified proteins, you can essentially properly treat somebody really quite easily. Now they have to get repeated treatments. Because of that, folks have started to look to gene treatments. So the vector of choice that has been chosen is the adenovirus associated virus. So adenovirus associated virus is kind of like an adenovirus parasite. When the cell gets infected with adenovirus, AAV kind of piggybacks on it. It uses the adenovirus components to make more of itself. So it can't divide in cells unless the cells are infected with adenovirus. The beauty of this virus is that it's very small. These genes are not very big. So you can put them inside this particular gene. You then use a commercially available adenovirus that's been genetically killed. It'll infect cells and it won't cause productive infection, but it'll let AAV essentially infect, except AAV will just make lots and lots and lots essentially of the clotting factor. So you can infect the bone marrow with this, and it will essentially genetically engineer the bone marrow to make a clotting factor. Kind of cool, huh? Now, the problem with this is that it tends to give you maybe a year or two of clotting factor production, and then it tends to stop. And you need to get this done all over again. But that's 2 years of not having to go to these treatment centers and getting a needle stuck in your arm to get these factors every couple of weeks or so. So which would you rather have? Most people, if they get 2 years of treatment, are really going for this. This is still used on an experimental basis. These are in clinical trials. The FDA has not yet approved them. And most of the clinical trials, consequently, are relatively small. They're not huge. So you have maybe a few hundred people in these trials. Seems to be well tolerated. Seems to give some response. So there are versions of this, both for hemophilia A and B, but it's still experimental. Maybe in the future, we'll see this commercially available, but until then, it still remains experimental. Now, an associated syndrome is so-called von Willebrand's disease. And von Willebrand's disease, because the von Willebrand factor is a protein that will carry factor VIII, you have function essentially that can look a lot like hemophilia A. But in fact, your hemophilia A is fine. But in fact, it's, and the labs for this also look really similar to hemophilia. But it's not a deficiency in factor VIII. Instead, it is a deficiency in von Willebrand factor. Von Willebrand factor also has been effectively cloned, overproduced, and can be given to people as well. Same thing with factor 11 as well. Acquired hemophilia is due to antibodies, and they appear during adulthood, and it's not clear why they appear, but these are antibodies against your own clotting factors. They seem to be the result of certain other types of autoimmune diseases. So this is pretty rare, but if it happens, essentially, suppressing the immune system seems to be one of the ways essentially to get around that. Also remember that in young babies, vitamin K is not found in breast milk. A lot of our vitamin K is made by our intestinal flora. Babies don't have that intestinal flora yet. That's why newborns, both in this country and in Europe, usually get a shot of intramuscular shot of vitamin K. That's to give them enough vitamin K to properly clot their blood. If they're not clotting their blood after they've been born, and just like in our little clinical vignette, the kid was still bleeding, that kid probably needs a shot of vitamin K. And a vitamin K deficiency, you'll have increased PT time and increased partial thromboplastin time as well. All right, summary. Hemophilia A is caused by defect in factor 8. Hemophilia B is caused by a defect in the gene encoding factor 9. Both of these are X-linked. They're inherited in an X-linked fashion. Only females can carry them. And females will pass it on to their sons. If they pass it on to daughters, the daughters will be carriers. The only way daughters can be hemophiliacs is if they're homozygous, in which case the dad would have to be a hemophiliac as well. Pretty rare. And hemophiliacs will present with the things we talked about, bleeding into the joints, hemorrhages, bleeding into the muscles and other types of these tissues, hematomas. They show a variable degree of clinical manifestation depending upon how the clotting factors are, how badly they're affected. You screen for this with the activated partial thromboplastin time and for thrombin time. You also look at platelet levels, fibrinogen levels. You'll have elevated activated partial thrombin time, which will have normal PT, normal platelets, and normal fibrinogen levels. And if you really want to confirm it, you can send the genome out for sequencing. That's a possibility too. The diagnosis, though, is typically made in the laboratory, taking the blood, adding back factors to eosinophil clot. And based on that, you're going to essentially determine how they're going to be treated. People with mild disease can be treated with vasopressin and other things like that, but most people are treated with intravenous introduction of the protein purified clotting factors. There is also a blood product. It's a concentrated blood product that contains clotting factors. The blood is taken, the erythrocytes are removed, and then the proteins in the plasma are concentrated. That is a concentrated thrombin product. That is given as well. And in fact, that's cheaper actually than the purified clotting factors. That can, most hospitals can actually give you that. You don't have to go to a hemophilia center for that. You can usually, hospitals can usually purchase those products and have those for, and you can usually get those at a doctor's office. Doctor's offices, if they have hemophiliac patients, can order those. You can usually, the kid can sit there and get those. Okay, family history, very important. Joints, you need to evaluate the joints and you do range of motion, pain, things like that, and then baseline labs, things like that. You get the drill. Any questions about hemophilia, the genetics of hemophilia, the care of hemophilia, manifestations of hemophilia, what the responsibility of the nurse might be? When a hemophilia kid comes in, your job, of course, will be to just really look the kid over, look for hematomas, look for ecchymoses, look for the hemorrhages, things like that, and what have you. If you see anything, what happened, the kid was trying to learn how to walk and they took a tumble, what have you. Kids with hemophilia, of course, they can't play any contact sports, obviously. They can do, gaming or something like that, but they, no football or soccer or, something like that.
No questions? No, all right. Then let's take a look at sickle cell disease.
Now, with sickle cell disease, hemoglobin is a 4-subunit protein, and it consists of an alpha globin and a beta globin subunit, and an alpha globin and a beta globin subunit. So it is a tetramer, but it's a tetramer made of 2 different globin proteins. And each of these also have in them a heme group. And the heme group is going to be the main group that will bind the oxygen. So in sickle cell disease, the mutation is in the gene that encodes the beta globin protein. And it occurs at the front end of the protein. It is actually amino acid number 6. You change a glutamic acid. This is a negatively charged amino acid. You have a single base change that changes this to a valine. This is negatively charged. This is hydrophobic. By putting a valine where there was a glutamic acid, you make a surface that is hydrophobic on the protein. That surface allows beta globins essentially at low oxygen tension to polymerize. So they polymerize and they make these cable-like proteins inside erythrocytes. And they take the normally dished erythrocytes and they stretch it out into a moon-shaped sort of structure-like cell. And the cell also becomes very stiff. So the cell becomes stiff when it's trying to squeeze between the nooks and crannies of the spleen. It gets stuck because it can't show its flexibility. It's too stiff. Also, it will have a tendency to stick to endothelial cells. And it sticks to endothelial cells and they essentially line up. It can plug capillaries and things like that, and it can cause infarctions. So therein lies the rub, essentially. This single base substitution causes a single amino acid change. That single amino acid change confers new properties on the hemoglobin. So this particular allele, as it is designated, is the so-called hemoglobin S allele. The wild type allele is called the capital A allele. Those that have the mutation at codon number 6, they are the so-called S allele. And they will cause the sickling predominantly under low oxygen tension. What tissues in your body are show low oxygen tension? Will be your lungs,
So Natalie over there shaking her head. Why not, Natalie? Yeah, you breathe in. Of course not. Right. So it's not going to be the lungs. It'll be places where hemoglobin is giving up a lot of oxygen. So tissues that demand a lot of oxygen. Can you think of some tissues that demand a lot of oxygen? Muscle. Aerobic muscle requires a lot of oxygen. You don't believe me, just ask Natalie when she's on the basketball court and running from one end of the court to the other. Do your muscles require a lot of oxygen, Natalie? Yes. She responded just like that. Or ask any soccer player or whatever. Muscles require lots of oxygen, particularly slow twitch muscle. And your skeletal muscles have a mixture of fast and slow twitch. So this mutation confers a new property. So it's either called a novel property or gain of function mutation. Gain of function mutation. All right, with me so far? All right, so with the sickling of the red blood cells, the sickling is going to produce two important things. One is vaso-occlusion. They're going to get stuck in vessels and occlude them, cause infarction. And they're also going to cause hemolysis. Because those red cells that are sickle, they're going to be a bit more fragile. So the hemolysis can be intravascular. So the red blood cells will be prematurely destroyed by the vasculature. It can also be extravascular, meaning they're going to be engulfed by macrophages in the spleen and liver. So in the case of intravascular hemolysis, you're going to have hemoglobin and the enzyme lactate dehydrogenase spilling into the plasma. That's and. That's lactate dehydrogenase. Hemoglobin when it's free in your blood. Does it stay that way or does it tend to get bound by something? Bound. Who binds it? Or excuse me, what binds it? No, tends to get oxidized when it's out in your blood. The iron's not much use when it gets oxidized. So this will then be bound by blood protein heptoglobin. I don't know if that rings a bell from A&P or not, but heptoglobin scavenges for free hemoglobin because free hemoglobin's got iron in it. Iron's a nasty, nasty, nasty oxidizing agent. You don't want free iron wandering around the body. Then you be very bad, very bad, very bad. Heptoglobin is then going to take it to the liver
where it gets recycled into unconjugated bilirubin. So liver, and it gets into unconjugated bilirubin. What happens when bilirubin levels get too high? What's that called? Jaundice. What's the first tissue to turn yellow in jaundice? You're good. Sydney's absolutely right. The sclera of the eye, the collagen has a high affinity for bilirubin. So one of the first places you'll see it are the whites of the eye. That's what you're going to check in a sickle cell disease patient. You'll be pulling their eyelid down and looking at that sclera. Because if the yellowing won't appear in the skin first, it'll appear in the sclera of the eye. So you're going to look at the eye. With extravascular hemolysis, the red blood cells are gobbled up by stationary macrophages. So the hemoglobin and the lactate dehydrogenase, they get kept within the cytoplasm of the macrophage. But eventually, you're going to have more unconjugated bilirubin. So we are upping the unconjugated bilirubin. That's going to lead to scleral icterus. That's the yellowing of the sclera of the eyes. Jaundice, that's the yellowing of skin and tissues in general. And then you can also get bilirubin gallstones. So these are the consequences of the hemolysis. When you do nursing fundamentals, you will probably be taught something called a Murphy sign. A Murphy sign is a sign for gallstones. You have the patient lie down, you tell the patient to relax. You then take your fingers, you put them underneath the bottom of the rib cage, and if the patient winces, that's a Murphy sign. You also can feel the gallstones sometimes. So put your writing implement down. Go ahead on the right side, feel the bottom of your rib cage. Exhale, relax, and just try and feel underneath. Okay, now it doesn't feel nice, does it? Well, I didn't see anybody wince when you did that. Your patient's going to wince, it's going to hurt. When they do that, they wince. When they do that, that is a positive Murphy sign. So you need to, checking eyes, you need to be checking for Murphy signs as well in your patient. Now, with this increased loss of red blood cells, what's going to happen to the RBC count? It's going to tank. So the bone marrow now is going to rev up. And it's going to release more red blood cells. So it needs to recruit more bone for bone marrow. And the place you're going to see this is in the cheeks. So you're going to get enlarged cheeks. You have increased medullary cavities. You may even see so-called extramedullary hematopoiesis. Extramedullary hematopoiesis will occur in the liver because of the need for red blood cells, because you're just chewing them up constantly.
Extramedullary hematopoiesis. That's the case with the hemolysis. What about the vaso-occlusion? Vaso-occlusion usually occurs in capillaries, doesn't tend to occur in the larger vessels, tends to occur in capillaries. That causes ischemia and it causes pain. And I don't mean pain, I mean pain. People with sickle cell disease are in constant agonizing pain. And you get these conditions in individuals with sickle cell disease. They're called sickle cell crises. These are due to vaso-occlusion crises. In these crises, the pain will start suddenly. It will last from hours to days, and it's excruciating. Any part of the body can be affected. It will typically affect the same parts of the body over and over and over. And the severity can vary from one crisis to another. So if it occurs, say, in the bones of the hands or the feet, it's a dactylitis. If there's swelling and pain in the fingers and toes in those cases. If it occurs in the hip, it can cause avascular necrosis. If it occurs in males in their penis, you can get priapism, where you have this painful, prolonged erection. You can also get it in the cerebral vasculature, causing a stroke and mental status changes, and something called Moya disease. Moya disease comes from the fact that when you look at it with imaging, the vasculature looks like there's a puff of smoke because the vasculature, because of the occlusion, is starting to dissolve or something. That's what it looks like. So the puff of smoke you see on radiographs of the cerebral blood vessels will develop over time as the arteries start to get blocked. It occurs in the kidneys, you get necrosis, hematuria. Occurs in the lungs, you get shortness of breath. And then their oxygen levels will sink even lower and what have you. And if it occurs in the spleen, it can lead to a splenic infarction. So as the cells give up their oxygen, the hemoglobin polymers with the mutant beta subunit will start to kind of line up into these rigid cables. You deform the red blood cells. They get stiff, they get sticky. They occlude small vessels. And you get infarctions usually in multiple organ systems. You also get anemia because of the hemolysis. And this is inherited in an autosomal recessive pattern. Except that someone with a single allele of the disease can also show sickle cell disease as well. Now, the really severe case would be those who are homozygous. People who are homozygous tend to not live for very long. People who are heterozygous for this condition, however, can also show the sickle cell trait. Now, if you live in areas where malaria is endemic, it turns out that when the merozoites try to infect the red blood cells, if they infect a sickled red blood cell, it's an abortive infection. So as the merozoites emerge from the liver, they start infecting red blood cells, and a bunch of those infections are completely aborted. So this allele confers some resistance to malaria. That's why
this particular allele is at higher frequency in areas where you have endemic malaria. So you see it in Western Africa. You also see it in Southwestern Asia. And you used to see it in the Mediterranean, but after World War II, the Allies sprayed all that area with DDT, and all the malaria-carrying mosquitoes were dead. So there's no more malaria here. We did the same thing here, which is why DDT levels, you can still find them in soil samples in some places, but there aren't very many mosquitoes that carry malaria. So the prevalence, at least in this country, is about 1 in 1,000, and it tends to be found predominantly in African Americans. Those of a Latin American heritage, the incidence you can see is not nearly as frequent as it is in African Americans. It's also going to depend where in Africa they're from. Now, most African Americans in this country, their heritage tends to be from West Africa because that's where the slaves were taken from. If you go to the other side of Africa, you don't find nearly as much malaria. The environment is just not as good for an off these mosquitoes. But if you go to West Africa, that's really where you find most of it. So most of the ones, African Americans who are descended from slaves. Question? No, you're itch. Okay. Are going to be descended from West Africa. You'll also find it in Cuba, parts of South America, parts of Central America, Saudi Arabia, near the coastal areas of Saudi Arabia, not interior. I'll call Saudi Arabia desert. It's too hot for mosquitoes there. India, along the areas where the Ganges River, for example, the coastal areas and the riparian areas, and the Mediterranean regions. A lot of it has been removed from there. And so this is so-called ethnic variation of allelic frequency. And so I've estimated some 2 million Americans carry the trait. There are good genetic tests for carrying the sickle allele of beta hemoglobin. They're commercially available too, and they're not that expensive, but they are covered by insurance. Newborns in the US tend to be tested for this trait, typically. And usually kids with it will, usually around 5 months of age, will start showing symptoms because that's the time when the fetal hemoglobin gene expression starts to diminish and the adult hemoglobin now will start to be made. And you get an enlarged spleen. That's probably one of the big things you start to see, of course, anemia, pain, failure to thrive, multiple infections, and then swelling of various organs. The extremities, one of the big places because of that vasoactive occlusion. All right, so that is about all we have time for today. We will continue this on Wednesday. Remember, we have a test on Friday. There is a site open for you to submit questions. There's a discussion board on Blackboard. Did you guys all find it? So I haven't checked it yet, so I haven't taken a look at your questions just yet. But we will take as many questions as I can. I'm going to have 50 questions. This will be over chapters 1 through 8. Chapters 1 through 8, that's more than enough. Anything else? Any questions you have before we adjourn? No? All right, then I will see you guys on Wednesday.
Wow.